Health equity has long been a principle of quality healthcare, but health equity has faced resistance in 2024, including at the ballot box. What does that mean for health equity in 2025 and beyond? I'm Andy Reynolds. Today on Quality Matters, highlights from a panel discussion at the NCQA Health Innovation Summit in November 2024, which focused on these topics. The panel moderator was Dr. Bryan Buckley. He was NCQA's first Director of Health Equity Initiatives. Here's Bryan.
I'm now head of public health at Care First Blue Cross Blue Shield, where I lead equity strategy and public health partnerships. But I am also a super proud NCQA alum. One of the most vital things that I learned at NCQA was there is no quality without equity. And I've definitely taken this forward. So I'm honored to moderate this session.
Much of the panel conversation focused on what we mean by health equity. The takeaway is that equity means everybody. But instead of getting lost in labels, it helps to focus on underlying values. Here's panelist Tosan Boyo, president of East Bay Market at Sutter Health.
Everyone talks about health equity. People believe they understand it. People are constantly hearing about it. We've talked about health equity quite a bit in the past 5 years, but then I don't want health systems to start losing the thread as to, oh, we talk about it, therefore it's happening. What we're doing is fundamentally about morbidity and mortality. Our work is to ensure that no population is dying or getting sicker than the other. We want to make sure no one is dying or getting sicker at a higher rate than anywhere else.
We featured Tosan Boyo in Quality Matters episode 11. We suggest you check out that episode to hear his thoughtful, specific ideas on enhancing health equity in the health system that he runs. The panel urged the Nashville audience to think broadly and remember that equity means more than just race and ethnicity. I spoke with Bryan after the panel discussion. Here's how he frames the reminder that equity means everybody.
Everyone across the political spectrum wants high-quality healthcare. The question is, how do we get there? We know that disparities and inequities, it hurts us all. It costs a lot of money. It causes a lot of moral and economic pain. I don't think anyone has the golden answer. And so we have to frame with an eye towards action. And the action is high-quality, equitable healthcare. I think we're going to see different approaches in this new administration. One of the things I am looking forward to is looking at rural health, which has a lot of disparities. Maternal health is something to focus on because we see disparities around maternal health. There are some new areas around disability as we think about veterans. There's a lot of work out there in the health equity space. Let's focus, make sure that we're improving people's lives.
Panelist Dr. LaShawn McIver, Senior Vice President and Chief Health Equity Officer at AHIP, has a specific, practical way to check for equity. Think about who you don't see and who you don't hear.
You have to understand who are the voices that are missing. We have to start looking around our rooms and seeing who should be in this room right now. I am happy to say I'm starting to see more and more new faces. And that is a part of the transformation that's needed. I've had the opportunity to travel to different parts of the country. And it wasn't until I did some work in Alaska that I understood their challenges in a whole different way. And then I began to think differently about what do we need to do from the seats that we're sitting in to fix that problem.
Bryan, speaking of definitions and terminology, one thing that surprised me is the acronym DEI did not come up once during the discussion in Nashville. What do you think about that?
I don't know if it surprised me. I view DEI work and health equity work in a separate way, and you have to work on your internal work before you can do really good external work around representation and making sure we have diverse perspectives, and that collective intelligence can only be as strong as the diverse people within your organization. That was present actually at the Health Innovation Summit because we saw the diversity, not just from a race ethnicity perspective, but from a rural perspective, nursing homes. When we talk about diversity, you have to think about that broad spectrum. Health equity is really the implementation of collective intelligence into how do we move processes, systems, and people to achieve better outcomes for people within communities. There's a very large spectrum that we're talking about, not just from one or two perspectives, but making sure that we're meeting many different people where they're at.
I have a theory that DEI should be called dignity, fairness, and respect, since those are the underlying values or aims. What do you think?
I would say that resonates because that's really at the end of the day what the assignment is. I worked a lot in patient safety movement. And similar to the quality movement, dignity and respect are one of the most salient points in patient safety. Did people feel like they were cared for and that they could get their needs addressed while they were in the healthcare ecosystem? People should be able to go to healthcare and be their truest selves and know that they can get the best care possible. And so it goes back to NCQA's vision about how do we get better healthcare, better choices, and better health. That encompasses how we should think about DEI as a whole, that we do make sure that we have high quality healthcare for anyone.
Another takeaway from the Nashville panel: health equity is connected to other quality priorities, including data interoperability and digital quality measurement.
One thing I appreciated while I was at NCQA is interoperability. And how do we create digital quality measures that make it easy and interoperable? And the idea, doesn't matter where you are, your information can go with you. Interoperability could be an opportunity for intersectionality. When we start thinking about that intersectionality and broader demographics, whether you're in a rural area, whether you're a veteran, really thinking about compounding disparities, we need to get better with getting data faster, quicker to respond, because of the way we have a lot of data, claims data, we don't really know there's a problem until about 6 months after. So those are the things I think about that role of intersectionality and interoperability.
Camille Burnett, Vice President for Health Equity at the Institute for Healthcare Improvement, pointed out that equity has practical implications for data collection.
People are in their heart convinced that this is a good thing to do. However, data collection is important. Having access to that data, being able to have the right types of data so that you can stratify that data, and then that data can guide you to close those equity gaps is important. Some systems do struggle with getting access to the right types of data and how that data is collected, et cetera.
Bryan pointed out to the panel that health equity faces resistance. Daniel Dawes, Senior Vice President for Global Health and the Dean of the School of Global Health at Meharry Medical College, urged the audience to keep things in perspective.
We know health equity is being thought of by healthcare delivery, by health plans, even by our federal government. We also feel the resistance to transformation of our healthcare systems to be equitable for every single one, no matter their background and location. So Daniel, can you talk about the political landscape that's affecting the ability for us to address health equity?
We got to stay motivated, stay focused, and of course, stay innovative. This is not the first time that we have seen retrenchment and regression. I look at it in terms of 4 awakenings around health equity. The first occurred during the Lincoln administration, where they tried to pass the most comprehensive health reform law, only to have opponents undermine it 7 years later. We had that retrenchment. The second awakening happened about 2 years into the civil rights movement, after Dr. King made the statement that of all the forms of inequality, injustice in healthcare is the most shocking passage of Medicare, Medicaid, Civil Rights Act, Voting Rights Act, all of these egalitarian policies. After that, we had a slight retrenchment period. The third awakening happens, and folks said, we address the overt forms of discrimination, and yet we still see striking disparities in healthcare and in health status. Again, we had a retrenchment. Now we're in that fourth awakening. We are seeing traction where we're allowed to center health equity to a degree that we've not been able to do before, and to make sure that we go to that structural level to develop the interventions that we know work. So I guess my bottom line here is that it's not the first time we've seen this. We now have an opportunity to go even further, and we have to stay motivated, stay focused, stay innovative.
Another lesson from the panel discussion was there are practical, specific things health systems can do to enhance health equity. Again, here's Tosan Boyo.
My mission right now is how do we move from activity to productivity? It's time for delivery systems to start saying, okay, what gaps are we closing? How are we holding ourselves accountable to our quality metrics so we can be productive? And that starts with how complete is the data that we're collecting across acute care, ambulatory care? And then after that, What theses are you developing about what gaps you want to close? If you're in ambulatory care, how are you ensuring that your third next available appointment is equitable across race, ethnicity, and language? If you are in the ED, what is your thesis on left without being seen? How are you holding ourselves accountable as relates to our quality metrics so we can be productive?
Bryan, we'll wrap things up in a moment. What else do you think people who care about quality should know about health equity as we head into 2025?
You can't really take out equity from high quality healthcare because we know when high quality healthcare was defined, equity was a core tenet. There's many different flavors. Some people like to call it whole person health because at the end of the day, that is what health equity is. We want to make sure we are looking at you as a whole person.
And remind me, please, Bryan, whose definition of quality first included health equity?
So that's Crossing the Quality Chasm. I believe that paper came out in 2002 to really define 6 tenets of what high quality healthcare was. It has to be efficient, effective, timely, person-centered, and equitable. Equity was the forgotten aim because when these tenets were put in place, it was the hardest one to attain. It required thinking outside the box. When you look at timeliness, you can always say, hey, I shortened the time. Even person-centered, you can get there a little bit easier. But equity, it can be really hard because it's part of the reason the language changed around addressing social determinants of health to social drivers of health.
That's interesting. Can you tell me more about that? Tell me more about changing the term social determinants of health to social drivers of health.
A lot of people heard the word determinants and felt too deterministic. Like, well, I can't do anything. But if there's a driver in health, that means there's something that we have ability to influence. It's always been a really hard thing, but still work that needs to be done. And when we think about the World Health Organization definition of health, it's not just physical health. We're also talking about social health. Do you feel socially connected? The Surgeon General came out with a report on loneliness, and do people feel socially connected? That can impact health. Health and well-being is quite broad.
The panel discussion and my follow-up conversation with Bryan ended on an upbeat note.
The last thing I'll say is we have to accept that health equity doesn't end. There's this idea of like, okay, at some point it's no longer going to be trendy, but we don't stop doing quality work. It is fundamentally how we validate and verify that we're actually improving quality.
You can't leave out here without a great John Lewis quote. John Lewis said, "Do not get lost in the sea of despair. Be hopeful. Be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It's the struggle of a lifetime. Never be afraid to make some noise and get into some good trouble. Necessary trouble." And we know the work that we do here in health equity, it's necessary trouble for the future generation of our country and our world.
Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.